So patients come into the breast center for many different reasons. One could be to just come in and get their annual mammogram, which I recommend starting at the age of 40 and coming every year. The other way a patient may come in is somebody with symptoms, such as nipple discharge or a lump, or some other reason that they think something's changed in their breast. And then what we'll do is do targeted imaging at that time with the mammogram or tomosynthesis imaging as well as ultrasound. And then we'll talk with the patient and give them the results. And if the patient needs a biopsy, we'll go ahead and proceed to the biopsy. But some patients may end up needing extra imaging in 6 months to just kind of watch an area that we think is probably benign, less than a 2% chance of being cancer, and we just want to keep a close eye on that. About 60% of the things that we biopsy come back something benign and nothing to worry about. Some of these may come back malignant, and then the discussion with the patient's surgeon or nurse practitioner at that time as to what the next steps are. It really depends on what kind of breast cancer. There's so many kinds of breast cancer, and we're really good now at targeting the treatment to the particular type of breast cancer that we diagnose. A lot of patients are afraid to come in because they're afraid of what we're going to find. If we can find something that hasn't metastasized or gone to the lymph nodes, we probably have about a 98% chance of a 5-year survival rate or a cure, as opposed to waiting till it's much larger. So being proactive and finding things that are much smaller at an earlier stage gives us a much better chance of curing that patient.